Hello, everybody. Surgical management of the thin endometrium. First of all, I'd like to say that not all cases of thin endometrium are amenable to surgical treatment, and that the thin endometrium secondary to intrauterine adhesion may be suitable for it. I'd like to clarify the definition of Ashland syndrome, which is defined as the presence of intrauterine adhesions or fibrosis, together with one or more associated symptoms, including amenorrhea or oligomenorrhea, infertility, or recurrent miscarriage. As regards the treatment of intrauterine adhesions, I'd like to say that medical treatment has really no benefit at all, and that stem cell therapy is far from a reality. Surgical treatment, I think, is the only option. In this lecture, I'd like to go through the following areas, including the preoperative assessment, operative techniques, post-op management to prevent adhesion reformation, surgical consideration in the primary prevention setting, and what is new with surgical treatment. First of all, preoperative assessment. It is often said that hysteroscopy is the gold standard for the assessment and diagnosis of intrauterine adhesions prior to surgery, but it is not foolproof. In this case, you'll see that this is a case of hysteroscopy performed by a rather experienced reproductive medicine specialist. You see the ostium, the adhesions in the lateral side wall, which was missed by the colleague. And when on withdrawing the hysteroscope, you see it more obvious on the left lateral side wall, like this. So really, hysteroscopy is really only as good as the person doing it. Another preoperative assessment useful is the ultrasound. Sometimes it might be unremarkable, but at other time, it might show up a thin endometrial or irregular endometrial echo in the lower half of the cavity, as in this case. At other time, the only clue to the presence of intrauterine adhesion is a small amount of fluid in the endometrial cavity. And on other occasion, there might be multiple small fluid spaces, suggesting that there are multiple adhesion bands in the uterus trapping the fluid in different parts of the endometrial cavity. In this case, you see a larger amount of fluid trapped in the cavity and the so-called bridges between these fluid spaces. It might be a clue to telling you that even if you enter into the mid-cavity, there is yet still another cavity hide up into the uterus, fundal part of the uterus. I also find the 3D ultrasound being more informative than the 2D in many occasions. As in this example, you see irregular side wall adhesions, typical of marginal adhesions. And so this is what you would expect when you go in and do the hysteroscopic surgery. On this occasion, you see an area in the mid-cavity, in the middle part of the uterine cavity, which was confirmed later on by the hysteroscopy. As regard operative techniques, I would like to say that there are two traditional techniques, the cold steel and the hot wire or the diathermy. So it depends on which technique you normally use, but in the first situation is using the scissors. This is a moderately severe adhesion in the uterine cavity, and you see the scissors is being used to gradually divide the adhesions, bit by bit. You see also that the scissors is not only useful in cutting the adhesions, but it can also be used to dissect the tissue around it before you're making the cut. So I'll show you in a minute. So this is the adhesion, and use it to dissect, and so that you're making the operation a bit safer. So dissect and then cut, and then dissect and cut. It's really a very useful technique to do in the presence of severe adhesion obscuring the view in the uterine cavity. In this example, again, there were present moderately severe adhesions in the lower half of the cavity, causing constriction, making it much more narrow. And again, in this example, a pair of scissors has been used to cut away the adhesion bands bit by bit. So there you are. So the advantage of the cold steel or the scissors is that it is suitable, particularly suitable for endocervical and central adhesion bands. It might be used to dissect as well as to cut. It is safer in the case of an unexpected uterine perforation. It works with a small hysteroscope and therefore might not require cervical dilatation. It is therefore possible to be used as an outpatient procedure. The downside of the cold steel is rather slow and the scissors may be blunt. The other technique is the diathermy using a pointed diathermy, as in this case. It is showing a pointed diathermy is being used to cut away the marginal adhesions in the left lateral side wall of the uterus. So you can see it is rather quick. And on other occasions, the loop diathermy may be used to resect away the adhesion bands. As in this case, you see it's not just the adhesions, but this is a concentric band of adhesions, which would be best removed by resecting it all together rather than just cutting into it. So again, you can see that it is very fast in action. So the advantage of the hot wire is that it is fast, always cuts well, particularly suitable for severe side wall adhesions. And should there be any bleeding, it would also achieve hemostasis very effectively. The downside of it is it carries a high risk of damage to residual endometrium because of the burning, the diathermy injury to the endometrium that remains. And there's a greater risk to viscera in case of an unexpected perforation. There are new techniques though. The balloon has been used to divide and separate adhesion inside the uterine cavity under ultrasound guidance. It's been reported a few years ago by Saravelos and myself. So this is an example. You use a balloon inside the uterine cavity and inflate it, and by distending the uterine cavity, you can remove the adhesion band inside it at the same time. So this is an example using a Foley catheter. We cut away the tip of the balloon just to avoid the tip poking into the fundal part of the uterus. And this is an example. I use a gradual dilatation. So I instill about 3 mL of saline initially, then keep it there for a few seconds, then I deflate it. And then after that, I put in 4 mL of saline to inflate the balloon and deflate it again. And then later on, put in 5 mL. It is important to remember that in the process, there is no need to use more than 5 mL of saline solution. When you use excessive amount, it could break the muscle fibers and it can do more damage than good. This is an example of a moderately severe intrauterine adhesions. You can see a narrow pathway towards the right side where the balloon catheter can just go in. And after doing the gradual dilatation 3, 4, and 5, you will see that the cavity is instantly back to nearly normal dimension. And when you look closer into the ostium, this is the right ostium, and this is the left ostium, which look quite normal after a simple balloon distension therapy. My PhD student, Peter, published in the BJOG, this randomized control trial on intermittent balloon therapy in conjunction with the Fusing team and Professor Sa in Beijing on the use of the balloon to prevent adhesion reformation. And this is the study design. So we recruited 100 patients on each arm. In the control arm, they had second look hysteroscopy at 4 week, just 4 week post-op, and the third look hysteroscopy at 8 weeks post-op. Whereas in the treatment arm, we have additional 2 balloon therapies at 2 week and 6 week after the initial surgery. And the primary endpoint is the adhesion reformation rate at 8 weeks after the operation. You'll see in this figure that in the control group, the adhesion reformation rate was 40%, whereas in the balloon group, the adhesion reformation rate was down to 20%, representing a significant reduction. So the balloon therapy, the advantages are that it is suitable for corneal adhesions. It could be done as an outpatient procedure, and it is very effective in newly formed or reformed adhesions. The downside is it may not always work, especially in the case of dense fibrotic adhesions. And the new technique is the invisible knife. So you'll see in this case of intrauterine adhesions in the lower half of the uterine cavity affecting the right side, and you'll see the adhesions are being separated, removed by the invisible knife. You can't see the invisible knife, but you know it's working because the adhesions are being separated gradually. So the question is, what is the invisible knife? What is it? You see that it's nearly finished, and you'll be able to go into the uterine cavity very shortly, and there you are. So what is the invisible knife? Well, it is a hydraulic knife or water knife. It utilizes the energy generated when water is forced to escape under pressure to dissect or cut through a small opening to form a water jet. So in fact, the water knife has been used for many years in industry to cut metal, ceramics, cardboards, and many other objects. And you see it in action at this point, using the kind of very delicate shaped object. It cuts very well indeed. And so there you are, the finished product. So as for using the water knife, there are 2 important tips which I'd like to highlight to you. Firstly, you have to use sufficient pressure. I know we all use a water pressure of around 80 to 100 millimeter mercury when we are doing a diagnostic or operative hysteroscopy for most cases. However, for the invisible knife, you need to use a higher pressure of 250 to 300 millimeter mercury. Though it is safe because the high pressure achieved is only over the tip of the hysteroscope. It quickly drops to a safe level once the water is inside the uterine cavity, and especially if there's no active bleeding vessel, it is generally very safe indeed. The second tip is that you have to use the water knife at close range. For example, in this picture, you see the water knife is much more effective over the red arrow than the gray arrow, which is quite a bit of distance away. So the invisible knife or water knife, the advantages are that it can be done as an outpatient procedure. It is very atraumatic, hardly any bleeding at all, effective in newly formed or flimsy adhesions, and is particularly useful during second look hysteroscopy. The downside is it is ineffective for dense fibrotic adhesions. So to summarize the surgical techniques, I would say that optimal treatment of Ashman syndrome requires the use of different techniques for different types and location of adhesions. And I also like to add that ultrasound guidance is immensely useful. The second area I like to cover is the postoperative management to prevent adhesion reformation. Surgeons for many years know that intrauterine adhesion reformation remain one of the most significant challenges in the management of Ashman syndrome. It may occur in up to 50% of cases. So a number of adjuvants have been tried to prevent the recurrence, and the 2 most useful techniques which are used from time to time is an early second look hysteroscopy. When I say early second look, it's usually performed 4 to 6 weeks after the initial hysteroscopic surgery. And the balloon therapy may be continuous or intermittent, Continuous balloon therapy refers to insertion of a balloon immediately after hysteroscopic ileolysis, and then you leave it there for 10 to 14 days. The intermittent balloon therapy is one that I mentioned to you earlier. You put in the balloon, you distend it, only leave it for a few seconds, then you remove it. Estrogen therapy has been widely used, but there is hardly any objective evidence that it does work. I don't always use it. I only use it occasionally in very severe adhesions, especially in women who do not have regular cycles, and in whom I'm concerned that there is insufficient estrogen production. Anti-adhesion gel has been found to be useful in primary prevention of intrauterine adhesions, but I'll show you the data regarding secondary prevention in a minute, which is not so encouraging. Amnion graft and IUCD are rarely used these days. So one of the reasons is this meta-analysis, a forest plot showing among the 4 clinical studies published, the balloon therapy is significantly more effective than the coil in prevention of intrauterine adhesions. So nowadays I use the balloon, and I have stopped using the IUCD for quite some time. And this meta-analysis of several clinical studies, 5 of them together, comparing the gel versus the control, and you see that actually there is no significant difference between the 2 groups. So I don't use the gel often myself, rarely use them. So next is the surgical consideration in primary prevention. I would recommend that the first thing we ought to do is to avoid surgery. Medical treatment should be the first line option, and curettage of the gravid uterus should be avoided whenever possible. For example, in the case of termination of pregnancy, delayed miscarriage, and retained product of conception, because as we all know, one of the most important causes of Ashman syndrome is curettage of the gravid uterus. My second recommendation is that we should perform intrauterine surgery very gently, using the minimum amount of energy, be it mechanical or electrical, necessary to reduce tissue injury. So as an example, this is a case of a polyp which was resected. However, this is a case of resection without the use of any electrical energy. It's just using the mechanical energy generated by scraping using the loop. So in this way, it can avoid damage to the endometrium due to the diathermy process. The third recommendation I would make is to perform precision surgery. As in this case of a retained product conception, when you apply suction under ultrasound guidance, once you have confirmed that the sac has collapsed and the tissue been removed and the uterus is empty under ultrasound guidance, there is no need to do check curettage. The surgery could be stopped because the cavity is already empty. Finally, I'd like to cover what is new in the treatment of intrauterine adhesions. This video is from a nurse whom I saw last month. She came to see me because her periods are getting very light following a suction evacuation and curettage of the uterus after a miscarriage. You'll see that there are multiple adhesion bands inside the uterine cavity. And I removed the adhesion using a scissors as an outpatient procedure, bit by bit. What I did afterwards was to perform a balloon therapy 2 weeks later to stand the uterine cavity and remove any reformed adhesions. And then at 6 weeks, I performed a second look hysteroscopy. And you see that the uterine cavity was nearly completely normal, no recurrence of adhesions. The unusual thing about this, or new thing about this, is all this has been done under an office procedure without any general anesthetic. I think with modern equipment, improved technique, with the no-touch technique, ultrasound guidance, it is now possible to perform a significant proportion of cases of Ashman syndrome as an office procedure with the need to performing it under general anesthesia. So with that, I'd like to thank you all for your time, and I'll be happy to answer questions in the discussion session sometime maybe next week. Thank you once again.